Habari za asubuhi tena. Good morning na marahaba kwa wanafunzi wangu ambao wako hapa. Yeah, because at least I see some common faces here. But today we are colleagues. Some of them we've already served as colleagues. But please, you are most welcome to this session. Here we are being hosted by GLASS Project, and they are going to present their findings, and we, in general, we are going to share into those ones because this project really talks about us, and we are expected to make contribution to see how we can proceed. But prior to that, I have the honor of inviting the ambassador of Ireland, Balozi Nicola. Okay. Okay. At least, Ambassador Nicola is a current ambassador of Ireland in Tanzania, representing the government of Ireland in strengthening bilateral relations. Prior to her posting in Tanzania, she served in senior roles with Irish Aid, Ireland Development Cooperation Program, where she worked on key global issues including gender equality, health system strengthening, and sustainable development. Makofi matatu kwa balozi as she.
Asante sana. Habari za asubuhi. It's just fantastic to be here. I'm not very good on protocol, so I know we have our CMO with us, and really delighted to share the room with her. Very distinguished guests from Mzumbe University, and indeed from the University College in Dublin. Also our colleagues from the Health Service Executive in Ireland, senior leadership from there, and really delighted to share the room with them also today. Just to say a big warm welcome to everybody in the room. I think this is a really incredibly important event to look at women's leadership in the health sector. I really love the name of the research project, GLASS, Gendered Leadership Advancing Systems and Structures, because it reminds me also of breaking the glass ceiling, which we talk about a lot for women when they manage to go places that they haven't been before. And one I wanted to recall today is the 30th anniversary of the Beijing Declaration and Platform for Action. And that was gavelled in 1994, 1995 by your own Mama Beijing. So Mama Beijing, Gertrude Mongela, she was the Secretary General of the 4th UN Conference on Women, and that led to the Beijing Declaration and Platform for Action. And that's really the most significant global agenda for the empowerment of women and girls. And we continue to implement that today. And the work of GLASS is really significant in that regard. And we know since then, I mean, that's, what did I say, it was 30th anniversary, so it's 30 years since the Beijing Declaration. And since then, we have seen huge progress globally on the empowerment of women, on addressing some of the structural barriers to gender equality. And we have seen significant gains for women in leadership positions as well. But as we know, we still have a huge way to go. There's still very significant progress still to be made. And I think also we are unfortunately at present seeing and witnessing a global pushback on some of the key achievements that we have made over that 30-year period. The achievements that we've made on equality, on inclusiveness, and on diversity. And I think working collectively is now more important than ever before, not only to make more progress, but to actually protect the progress that has been made over those 30 years. So this collaboration today, you don't have to wait. Usually we have a little platform. Anyway, this platform here today is really important in that regard. And I think international collaborations such as you're seeing today between universities and with government play a fundamental role in driving gender equality through building coalitions, advocacy, knowledge exchange, and pooling resources and expertise for women's empowerment. And in this regard, my country, Ireland, we really recognise the role of academic institutions and civil society working collectively with government to make progress. And I think some of the progress we have to ensure is institutionalised. And that's why I like the emphasis in GLAS on systems and structures in order to ensure that it continues. Really on my own, in terms of my own country, Ireland, gender equality is one of our core values. It's central to our foreign policy and it's central to our international development policy. And we believe that achieving gender equality is vital to building fair, inclusive, prosperous and peaceful societies, which is also articulated in Tanzania's Vision 2050, which has human capital development as one of its key pillars, and within that, ensuring gender equality and women's empowerment. Ireland, again, just coming back to my own country, we work in different ways to advance gender equality and the empowerment of women and girls, including through our international diplomacy, including through our engagement in multilateral fora, like the UN Commission on the Status of Women, which is an annual event, really critical to hold ourselves accountable, to monitor progress, and to set further ambitions. And I think it's really important to have that vision and that ambition in terms of the gender equality that we want to see, in terms of the transformation that we want to see. Sorry, I've also I've mentioned our international development policy from Ireland, and that's really, really key to our work on advancing our gender equality priorities. And just here in Tanzania, I wanted to say that we put women and girls at the centre of all of our work at the Embassy of Ireland, and we take a three-pronged approach. So firstly, we focus on our diplomacy, our advocacy, our engagement with government and our partners to bring about change. We invest in programmes. So secondly, we invest in programmes. We work with partners to improve sexual and reproductive health and rights, address gender-based violence, tackle malnutrition, provide social protection, engage in climate mitigation, and build capacity. And thirdly, and I think this third component is really, really important, we work internally to bring about change within our staff. We build up the capacity of our staff. We build understanding about the structural barriers to gender equality. And we support them in their work, but not only in their work, but to bring about change in their own lives, in their own households, in their own communities, and indeed then in their own country. So I think these international collaborations are hugely important, but for women also, education has to be central to change. And access to education at all levels and access to quality education is hugely important. And promoting women in STEM, in science, technology, the E is engineering and mathematics. And really supporting women to go into the science fields is hugely important. And again, through our work, we have a fellowship program at the Embassy. We support young Tanzanian students to study to master's level in Ireland. We're also supporting a number of students here through the Dar Institute of Technology to undertake their masters in electrical engineering and other forms of engineering on energy efficiency. And I suppose a lot of embassies do that, but I think what we do that's maybe not different, maybe the same, but we're very intentional on ensuring that at least 50% of the fellows and the students that get support from our embassy, maybe the same, but we're very intentional on ensuring that at least 50% of the fellows and the students that get support from our embassy, maybe the same, but we're very intentional on ensuring that at least 50% of the fellows and the students that get support from our embassy, maybe the same, but we're very intentional on ensuring that at least 50% of the fellows and the students that get support from our embassy, maybe the same, and we're very and there are many, many examples on ensuring that at least 50% between Ireland fellows and the students. And my embassy has been based in Tanzania, and we're very and there are many, many examples on ensuring that. And I'd like to recall that in the 1970s, my embassy has been based in the province, and there are many, many examples on ensuring that. And I'd like to recall that in the 1970s, my embassy has been based in the province, and there are many, many examples in my lifetime. And I'd like to recall that in the 1980s,
But that was in my lifetime, and that was in my mother's
and that's changed my life, and I'd like to recall opening my door for men. That was in my lifetime, and that was my mother's success, and that changed my life. And I'd like to recall opening my eyes for men. That was in my lifetime, and that was my mother's success, and that changed my life. And I'd like to recall opening my eyes for men. That was in my lifetime, and that was diplomacy. And at that time, there were no female ambassadors in Ireland, none whatsoever. When I became an ambassador about 6 years ago, the first time, about 34% of our ambassadors of Ireland were women. Today, we're at 55% of Irish ambassadors all over the world are women. And I really think, you know, legislative change 50 years ago opened that door. But then the support, the collaboration, the mentorship, like you'll hear about today, all hugely important. Women have the capacity, women have the potential. Often they just don't have the support to actually realize that potential, or they don't necessarily have the opportunity to do so. So for all of the women in the room today, who it's fantastic to see everybody, I think providing that collaboration, that support, and supporting one another. We all need space to be and to be able to articulate our challenges and to look for support from one another. And I think that's really, an important aspect going forward. But I just wanted to commend Tanzania too for the incredible efforts that it has gone to promote women and to ensure equal participation of women across many sectors. We're seeing a female president for the first time. We see many female ministers, and they're fantastic role models for young women in Tanzania today. But there's still a huge way to go to get equal representation of women at the table in decision making, and again, huge efforts to ensure that that actually takes place. So listen, I'm going to just pause there, or stop there rather, and just wish you all very well. I'm really looking forward to the discussion today. I'm really delighted that our embassy is supporting this event and that my government has supported the research that has led to this, because there's learning here not only for Tanzania.
Clap 5, you clap 5. That is 355, isn't it? Okay, 355 for Madam Ambassador. Pasha, 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 choma. Okay, thank you. Okay, in fact, we are really honored we are here because of the Irish government. The project, the GLASS project, have been supported by the government, but at least we have the blessing of this event by the ambassador, so I think we are ready to go. So right now, I want to invite the PI, Principal Investigator of this project, and this is Professor Elish. Let me just end up with that first name. I don't want to break my teeth over the second and whatever. She is the Principal Investigator of the GLASS project, Professor of Health Systems and Director of the University College, Dublin, for the Interdisciplinary Research, Education and Innovation in Health Systems. Previously, a founder and director of the Center for Global Health in Trinity, Dublin. Naomba niishie hapo, because if I continue, I have 3 pages. Then we might find that instead of presenting whatever she prepared, we'll end up, nourishing her. Karibu sana, Professor Elish.
Thank you very much. Good morning, everybody. I'm delighted to be here to speak to you on behalf of the GLASS team, the GLASS research team, about our project. So together with my co-investigator, Professor Henry Malel from Mzumbe University, we're going to spend the next 25 minutes talking to you about the GLASS project. So I will speak to you about what we did in the project and why we did it, and Professor Henry will talk to you about the results from the project and the implications and where we would like to see the project going from here. And we'd also like to hear from you during the panel discussion about where we take the project next. So I suppose to begin with, I'd like to start by thanking our funders, as the ambassador mentioned, and we're delighted to have the ambassador with us today. Thank you, Nicola. The Irish government is one of the funders of this project, together with the Irish Research Council, now rebranded as Research Ireland. So we were very fortunate we wouldn't be here without that funding. But we also wouldn't be here without the support we've got from the Tanzanian side. So we've got huge support from a number of different ministries across the government, and I really would like to acknowledge that, and many of the people are here with us today. And Henry will talk to you later about our project team, but I suppose one of the things I wanted to say personally about the project team that has been working with us on this is that it's been a tremendous honour and privilege for me to work with the people on the project team. And we have had a long journey, and it's relevant, I suppose, to our topic here today, because when we first started recruiting for the project team, the researchers, we were faced with lots of male faces, and we were really faced with a dilemma. How do we run a project on gender when the researchers are male? But thankfully, we've had a journey, we've moved on from that, and I'm very happy to say we've had a fantastic group of young, bright, capable women working on this project. And I say group, the project has been 3 years, but no sooner have we recruited them than they've moved on to higher positions, which is tough for us, but great for them. So we've had, people who've been postdocs on the project who've moved on to lecturing positions, who've been poached by our funders. And we've had people who've been research assistants who've gone on to do PhDs. And I know I shouldn't single anybody out, but there is one person that I would have liked to have here today, but she's not able to be here. And she was a key component of the project, and many of you who are participants in the project will see her as the face of the project, and that's Agnes Mpinga. Agnes was the research assistant on the project and worked tirelessly with the site leads and the mentors and mentees, and the people in the room who are part of that group will know who I'm talking about. And she couldn't be here today because she's just started a PhD scholarship in Germany. So great for her. She even contacted us this morning to see if she could join by Zoom. But her commitment to the project, even though she has left, she still joins our weekly meetings. And the other person I really want to thank is Margaret, standing there at the back of the room, who will be familiar to the panel and everyone else in this room. Margaret Mwakalaza, who has come later to the project but has been the key to the organisation of this event today, and it wouldn't happen without you, Margaret. And Margaret is a very busy lecturer in Mzumbe. She's doing her PhD at University College Dublin, but she has given 100% to the organisation of today's event. So thank you. So let's get on to the business of the day. So can we move on to the first slide? So what is this project about? It's about strengthening gender-responsive leadership in the Tanzanian health sector. And really, I suppose, the key components are the gathering of evidence, making sure that everything we do is evidence-based, that we're using the best available science to implement what we're implementing. And we have a leadership training component to it and a mentorship program, and we'll explain to you why that is the case. So if we can just move on to the aims of the project. Oh, they're there. Okay. So the ambassador mentioned the importance, I suppose, of the structures and how you like the title of our project. And we are very much, I suppose, of the opinion that, for a long time, gender programs focused on the woman and fixing the woman. And many of you who are gender experts in the room will be very familiar with this. But it's now understood that it's not the woman that needs fixing, it's the system. So the systems aren't ready for women to operate to the best of their capability within them. So there are lots of barriers in the system, lots of policy and lots of guidelines and rules and regulations about roles and professions that prevent women from advancing. So this project is very much about addressing those system issues as well as addressing the empowerment of women and the education of women. And the second part of it, which is important to us as researchers, I suppose, is to evaluate it. And we evaluated it in 3 regions in Tanzania, and Henry will talk to you more about that. So can we move on to the next slide? So in terms of why we're doing this, many of you in the room will be familiar with the report by WHO and the Women in Global Health movement that came out in 2019 with the great title, Delivered by Women, Led by Men, which is referring to the health workforce. And, as you know, 70% of the health workforce is women, and 25% or less than 25% of women are in senior positions, or of senior positions are women. So that was a real strong calling for us to do something in this space. And as our ambassador mentioned, our international development policy in Ireland, gender is at the heart of that, and gender equality. So that was a key influencer in terms of our decision to address this issue. When we think about gender equality, obviously we think about SDG 5, but again, referring to you, the quality education, SDG 4, SDG 3 in terms of improved health is important, because we know that women are the primary users of healthcare services through their, I suppose, healthcare needs through the reproductive and childbearing and child rearing cycle, but also, when they start to be the primary carers for elderly parents and relatives. So women know what's needed in healthcare, so therefore having women in leadership and decision-making positions will result in better health services. And then also, more recently, there's been much more focus on SDG 8, because empowering women and putting women into leadership positions or enabling them to lead actually contributes to economic growth and to development of the health sector. So really important for all of those SDGs. The African agenda is very strong on the importance of promoting gender equality. Tanzanian's vision, DIRA 2050, and the health policy, and I suppose the strategic health planning process has also got gender at its focus. So I suppose, what's common in all of these documents is the need to advance women to promote transformative change, and also the progressing women advancement in leadership and governance positions, more particularly, I suppose, in senior managerial policy and decision-making roles. So that was really the influence behind the project. So I'm going to spend a little bit of time talking to you about this slide. It's very detailed, you don't need to read it all, but I suppose what I want to focus on here is how we implemented this project and how important that is. And it's really what we have learned from that implementation. So many people think of researchers as people who go out and gather the evidence and do, the first quadrant there. They try and understand the problem. And then that evidence could be handed over to the implementers to implement, and then the researchers are called back in to evaluate. So you're doing a triangle rather than a circle. What we tried to do with this project, and what we do in a lot of our projects, I suppose, projects certainly that I've been involved in, is go through the whole cycle. So we're not just coming at the beginning and the end. Yes, we're gathering the evidence, but then we are working with the stakeholders to co-design the solution. So we can take the best available evidence and try and put it into practice, but if it doesn't fit, we're wasting our time. And one of the things we did as part of that evidence gathering is we did a review to look at what was successful from the published literature, what has been successful in terms of leadership interventions. And shock horror, we have so many leadership programs in the world. We have the top universities, top management schools delivering leadership programs. About that amount of them are evaluated. Yes, they ask, what did you think of the program? Did you like the content, etc.? But in terms of what impact that leadership training, which is very expensive in many cases, has on the service itself, very little of that kind of evaluation. So that was really key in terms of influencing us as well. So we took all of the evidence, we spoke to the women in the first line management positions here in Tanzania, and then we went into a co-design process. So we gathered together in rooms, we worked with Poralg, we worked with the ministry, we designed the leadership program, we worked with the regional health management teams and the council health management teams to design the mentorship program. We made sure it was based on evidence, and then we said, you decide how it's going to be implemented. You make it fit to your purpose. So the implementation consisted of the leadership program and the mentorship program running alongside each other, and then we came back in to evaluate it. And going through that cycle is, I think, the key to the success of this program. And having all of those stakeholders involved and having them understand the program and really support us in implementing the program. And I know some of our site leads who are champions out there in the system are here today, so a big thank you to those of you who really helped to implement the program. So this is just a slide showing some of this co-design work. One of them is in a health facility where we went and sat with the managers of the different departments and divisions and really just chatted about what were the key challenges that they faced. And then also we visited, I suppose, for data collection, which is the top picture. One of the bottom pictures there is in the Poor Alg office, really getting into the detail of the leadership program. And then the last one is the co-design of the mentorship program, which took place in Arusha with a lot of the regional health management team and etc. So out of that came the GLASS mentorship guidebook, and that is available for anyone to use, and it is really what helped us to train the mentors who are now scattered through the system and who are continuing to mentor. So last slide is really, I suppose, telling you a little bit about what the programs contain. So with the leadership program, you know, we think of a leadership program as financial management, you know, strategic management, etc. We didn't do all of that. Yes, we taught them, I mean, a lot of them had that already, I suppose. We focused the program very much on what were the challenges, what were their really difficult issues in being in a management position. Things like conflict management, communication, but also really importantly in terms of women, work-life balance, and really just getting, I suppose, an understanding of, you know, how you can manage that, how you manage all the demands on your time, and that was really important part of the program. Networking and being able to advocate and really having a voice and being able to speak up, because, you know, in many cases we have women in the decision-making bodies, but they're not given the opportunities to speak, so making sure that that was something we addressed as well. And then if we can just move on, the mentorship program was quite an unusual program, and the only one of its kind that I know of, where we also involved male mentors. And we involved male mentors because men are the people in the regional health management teams primarily who make the decisions about promotion. So unless they see the women and see the women's capabilities, you know, they're hidden. They will never get selected for promotion. So having male mentors as well as female mentors, and each mentee had both a male and a female mentor, was key to that whole aim to address the structure of the system, not just the woman. So I'm going to hand over now. I think the next slide is who benefited. I'll hand to my colleague. I don't know if you want to introduce. Thank you very much.
That I will allow it to go because it is one presentation. She's a co-PI, and right now I would like to invite Professor Mole, who is a co-PI, but now he's going to share the results. When they are done with their presentation, that is when we are going to applaud for them. So those were just mangoes falling from the tree. It is not clapping. Karibu, Professor. Okay, Professor Harry Abraham Mollel is a researcher and consultant in health systems and local government at Mzumbe. He is currently a principal of Mzumbe Mbeya. Tusimshangae mweupe lakini katoka kwenye baridi. But again, his work, his professional work is centered around health systems, and also is teaching and researching on gender. Itabidi nije nimkague kama kweli hiyo gender anayosema, watasema you women, this is how you are supposed to be. And then
thank you very much. It's a good privilege to really present the result. As it has been presented by Professor Eilish, our intervention was involved with training, mentorship, which really gave us very good results within a short period of time. Slides, please. We presented the intervention in 3 regions, Kagera, Kilimanjaro, and Mzumbe, and we covered at least two districts within every region. And our coverage, we had a total number of mentees, 74, and the mentors, 77. As you could see, we have more mentors than mentees. And our design was involved having a female mentor and a male mentor. And the reason is to give more confidence to the mentees that they don't only receive feedback from female, but receiving feedback from female and the males gives you more confidence that the result that you are receiving is really true. What we have witnessed within that period, next slide please, when we compare the result from the baseline and the end line, we noted that the leadership ability of mentees has significantly increased. They have been able to be aware now that they are leaders, and they have been able to make decisions and they exercise the leadership role. The majority of them were able to demonstrate the leadership practices. They're willing and ready, and they could see that they have a role to play in terms of exercising the leadership skills in improving the role, the services that they are providing. The leadership self-efficacy of leadership was also increased in terms of confidence. They had confidence to really make decisions. They had confidence to exercise the leadership role. We also noted that it is improved the interaction with their bosses, but also the people that they are leading. Remember that we focused on, we started at the primary level, because when you look at the leadership landscape, you could find majority of females in the lower level, leading sections, leading units. But as you climb up on top of the ladder, the number of females start decreasing significantly. So our intervention focused on primary level facilities, because we wanted to see how we can help them improve their capacities and skills so that they can advance to the higher level positions. So what we actually received the feedback from the mentees themselves. They reported that the leadership skills and their confidence has significantly improved. They were now able to demonstrate it, and they were able to exercise what leadership requires. Their career advancement, they also, some were promoted during the period of some have been promoted from the level that they were to a more advanced level, but some were able also to compete to more advanced leadership positions. It has also helped them improve service delivery in the year, because they have now been very well organized in terms of supervising and in actually taking leadership actions, which they reported that it is really enabled them, it has enabled significant improvement of services that were provided in the facility that they were working on. There was also improvement in professional collaboration in terms of consultation with their bosses. They are now confident of interacting with the top leadership level to seek more advice, to interact, and their confidence to share their views in making some of the decisions-making activities take place. Peer support, they were able to support each other, and those who were involved in the mentorship program, they could now reach each other for advice and the guidance, but also balancing the work. Majority of them were now able to, because they have been more organized, to implement their daily activities within time and finish it within time. So they were able to complete the work activities within the required time, and also they saved their time to work for the family issues as well. Challenging stereotype that the confidence that we females, we are not able. Sometimes they say, well, can I really do this job? When you appoint them for the position, the leadership position, they doubt that they really are capable. But that during the period, they reported that we now have confidence to compete for any leadership position that comes around. What actually makes the difference about the GLASS project? As pointed out by the previous speaker, we did a co-design of the program with stakeholders. So the focus of the intervention focused really on issues that were blocking, were the barriers, the actual barriers for them to apply or to be ready to take up the leadership position. So that really enabled the interventions to be more effective, because it was addressing issues that they communicated by themselves. The mode of delivery was also very efficient because we did it in, online through the ECHO platform, which was really effective. And this is a very unique experience because sometimes the online programs are difficult to get participants participating in the program. But for this, they were really ready and willing to participate by themselves without a push, and we did not incentivize them. So it was also very cost efficient. We just, when we were initially thinking about the program, our doubts was to whether people will be ready and willing to participate in the program, especially when you are delivering it from the distance. Surprisingly, good and very high. As I pointed out, the mentor, every mentee had two mentors, one female and one male, and that also increased the confidence of the feedback that they were receiving on the changes that happened during the implementation of the project. The flexibility in the session, there was also, because of the use of online, they could meet, some of the interaction was done online and some of the interaction in person. The mentor and the mentee could meet physically, but sometimes they could use it, so that provided, it has been convenient and flexible for them to schedule any time during the day in which they can interact. Combination of leadership training, as we all know, we have had several trainings sometimes, and we ask ourselves whether there is follow-up and whether it's making an impact. But blending it with mentorship has really shown to have a bigger impact. What they acquired in class, they were able to really, to exercise what they learned in class. But surprisingly, even the mentors who were not required to participate in the training, they really participated. And that gave us the feeling that the demand of leadership training is very high. Calls for the program to be sustained, really trained mentors using skills to mentors. What we observed during the process is that even those who were not part of the program, the mentors, those who were mentored, were now able to extend the skills they acquired to other people who were not part of the program. Adopting the acquired skills in supervision, they have started to utilize the skills they acquired during the supervision process, which we thought that is a very an effective way of integrating as well with the supportive supervision. But there was also strong support for extending the participant in more regions. They reported to us that this program is really good, and it could be very effective if it be extended to more participants and extended to other regions, other districts. That also people at the high level, the early leadership positions, desired for the program to be offered to more senior leaders, so that they can acquire the skills, the mentorship skills, and this is very, very important because it will also provide them an opportunity to mentor the junior staff. The qualitative finding also give us on a high satisfaction and impact. There was high satisfaction to mentees. That's the feedback from the mentees and the mentors. There were a very high satisfaction that the mentees have been able to demonstrate the leadership, to demonstrate and practice the leadership skills. There was career advancement. Some received the promotions, and some were able to compete to higher position. But expansion of mentorship culture, there was people were, the mentors were able now to interact with people who were not even part of the project. So that was expanding, that has expanded the culture of mentorship and the leadership training. But program integration, they have, as I pointed out, they have started to integrate into the supportive supervision program, which to us is an integration, and this needs to be uplifted higher to the policy level, and they actually facilitate it to more other councils. Sustainability and scaling up, this is a high requirement. There has been really a high requirement to make sure that the program is sustained, and because of the the way it has been designed, it is cost efficient, so it is easier to integrate into the existing framework. In general, as a system, for the system, when you look at the benefit that we have, we have seen that mentees, there's been a growth in leadership and network. There is enhancement of commitment, enhancement of leadership capabilities among the mentees. But for the health system, there is the need for mobilizing support from males, influential leaders, which we actually involved during the implementation of the program. As I said, we did not only take females as part, so this expanded to look at the system, not only by female, but also
1 minute to wind up.
Okay, for the policy perspective, as it was pointed out, we have several frameworks that we are supporting, that has supported the program. So system-wise, mentees, we have the policy supporting it, but we have expanded the scope of implementers and the stakeholders who were involved in the implementation of the program. The sustainability, why sustainability? We really need sustainability, as I said. Mentees, stakeholders themselves, we are calling for these programs to be expanded. There is a high demand of the program, but also it fits most of our frameworks, and we are all witnesses that most of our frameworks promote women in leadership, and sometimes 50-50, and we have not achieved it. So this intervention could be one of the good interventions to really promote the intention of the government of promoting women in leadership positions to reach 50-50. And how we have to include many stakeholders, Poralge, the Minister of Health, Minister of Education, and others in the implementation of this program if we really want to achieve the 50-50. And the training institution like Mzumbe could play a great role of supporting, providing technical support with the UCD, providing the core designing, provide technical support, but we also need finances from the government to allocate some resources, but also partners to support, to continue providing the necessary support to enable the programs being implemented. Next, please. This is the team that was involved in implementation of as you could see, I don't want to read Professor H. McAuliffe, and we also have seen some of the colleagues that implement the program together. This program, as a research, we have been able to do publication. We have already published three papers. We have a policy brief, which I think some of you have it in hands, that provide key messages, key issues that could be integrated into policy. But also have some other paper in the pipelines that has been already submitted for peer review, but also some are being finalized for publication to promote the idea and promote the result of what this intervention has been able to achieve. Thank you so much. Maybe I used more time, but thank you so much.
We say that since at least the core presentation have been made, before we go to panel discussion, let us applaud them for, you know, you have, both of them have used more than the time they were allocated. So we give them 333. Pasha, 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 choma. Okay, thank you. But, you know, I decided not to interfere with them because this is the core. We are here to receive the findings so that we can prepare to make contribution. Are we really in the right direction or not? You know, this is the 30th year after Beijing, and I'm really pleased to celebrate that one with this kind of events. But also is 35 years since Nairobi Forward-Looking Strategy, and 40 years after Mexico, when officially the UN accepted or put as one of the agenda the women issues. So literally we are here making history, and with that matter I wish to invite my panelists now. Okay. Asanteni. Naambiwa mnaruhusiwa kuuliza maswali saizi. If anybody has I forgot the mentees. One clap for me for forgetting there. Only one. Pasha, 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 choma. Thank you. We have 2 mentees who will share at least their experience. For them, 1 minute each.
Habari za wakati huu. Kwa majina naitwa Asteria Rocket Edward, natoka mkoa wa Kilimanjaro, Moshi Manispaa, kituo cha afya Shirimatunda. Kama tunavyofahamu, 60% mpaka 75% ya wahudumu wa afya ni wanawake. Kwa bahati mbaya sana, hatukuwa tumewezeshwa kwenye masuala ya uongozi. Kupitia mradi wa Grasi, tuliweza kuwezeshwa kama wanawake katika masuala ya uongozi. Mimi ni mojawapo wa wanufaika. Kipindi tunaanza mradi, nilikuwa ni mkuu wa kitengo cha idara ya wagonjwa wa nje, na nilikuwa nikiongoza watu 8 tu katika idara yangu. Kupitia mafunzo yale, uwezo wangu wa kujiamini, kutatua migogoro, namna bora ya mawasiliano uliweza kuniwezesha kugombea nafasi zingine za uongozi katika mkoa wa Kilimanjaro. Niliweza kugombea nafasi ya kaimu katibu mwenezi wa chama cha wauguzi ndani ya mkoa wa Kilimanjaro na niliweza kushinda. Kutoka kuongoza watu 6 ndani ya idara, sasa naongoza zaidi ya wanawake 1000, zaidi ya wauguzi 1200 ndani ya mkoa wa Kilimanjaro. Haya ni matokeo chanya ya mradi huu. Ninatamani serikali yangu ya Jamhuri ya Muungano wa Tanzania yenye sikio sikivu iendelee kusapoti mradi huu ili mikoa mingine ya nchi ya Tanzania iweze kunufaika na mradi huu. Ninawashukuru sana.
Tutawapigia pamoja na mwenzake. Karibu. There are 2 mentees. Karibu.
Habari za asubuhi. Naitwa Lucy Mapunda Matemanga, natokea mkoa wa Njombe, ni muuguzi, nafanya kazi katika hospitali ya mji Njombe alimaarufu Kibena. Mimi ni mshiriki vile vile wa mafunzo haya ya kupitia mradi wa Glass. Vile vile nimepata mafunzo haya kwa muda wa miezi 6 kupitia njia ya mtandao na nimenufaika sana. Mafanikio niliyoyapata, kwanza najiamini na nawajibika katika kazi zangu. Vile vile nina uwezo kikamilifu wa kuchanganua changamoto mbalimbali. Pia nimeweza kuunganisha wauguzi 81 na watoa huduma 28 kufanya kazi katika kushirikiana. Vile vile nimeweza kupanga mambo yangu, yani nikiwa kazini, nikiwa nyumbani na katika jamii kwa ujumla. Kabla sijapata mafunzo ya mradi huu, mimi nilikuwa ni kaimu muuguzi mfawidhi wa hospitali. Lakini baada ya haya mafunzo, sasa hivi mimi ni muuguzi mfawidhi wa hospitali ya mji Njombe. Asanteni.
Okay. Yeah, in fact, for those who don't understand Swahili, there is video clips that at least the sharing of the 2 mentees will be shared later. So let us enjoy the ones who speak Swahili and who can dance in Swahili, okay? Now for them, we give them 555 claps for our 2 mentees. Makofi pasha, 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 pasha. 555, isn't it? Pasha, 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 pasha. Choma. Okay, asante sana. Now it is time for the panel discussion. Please allow me so that if you have any question, because whatever they are going to discuss here during the panel relates to the same glass project. So So it will be of use if we wait for them also to share whatever they are going to share, and then we interact after their sharing, okay? So I have the pleasure of inviting Dr. Grace Magembe. This is my former student, my former colleague when she used to be Deputy Permanent Secretary, and now she is the second Chief Medical Officer in Tanzania, because the first one is Dr. Mary Nagu. She wrote that history of being the first female Chief Medical Officer, and Grace is the second. So at least both my students are writing history. Karibu, please. I also have the honor of inviting Rashid Mfaume, who is also a former student of mine. Karibu, although they are trying to be big and whatever, wanasema siku hazigandi, but right now Dr. Mfaume is a director. Number one is a public health specialist for 19 years. And right now he's the director with the Ministry of, President's Office, Ministry of PRAG. President's Office, regional and local government, whatever, but responsible for health. You know, we have very long names. I'm afraid I might end there. Dr. Mfaume, please. For them, I just say marahaba because they came there, found me, and they left me. Now they're that big. I have, okay, we were supposed to have Dr. Ntuli. Unfortunately, he couldn't make it. I think some of you had, and then we have Dr. Anna Temba. Please, karibu. Whether you like it or not, you'll be somehow a colleague of my former students. Okay. She's also a medical doctor, and she's currently serves as technical director and deputy country representative of Gender Health. Karibu sana. I also have the honor of inviting Dr. Com Henry, who is a chief clinical officer of the Health Service Executive in Ireland, where he provides national leadership on clinical strategy, quality, and patient safety. Karibu, is he? Oh. Okay, thank you. I think I better take this seat. You know, from age 24, I was teaching, and now I'm 64. So I really enjoy kind of the environment of teaching, of classroom. So these are my students today. Okay. As I said before, this program is really very crucial for us. Why? As it is mentioned, the population, let's talk about the population of Tanzania. 51.3% women, and then 47 point something men. But when you go to leadership position, you find 80% or slightly more than 80% men, and women will just be, you count, you know, in some cases. But when you go to employment in the health sector in Tanzania, I think women are more than 70%, although you put it 70, it is more than 70%, workers are women. But when you go to leadership within the health sector, that's when now the reverse. Those 25% becomes 80% at the top, and the women remain at the lower level. I think this is the responsibility or the challenge which this project is trying to address. And therefore, our panelists here will work on that one. And I think I'm going to begin with the Chief Medical Officer. I think we better go to the chief medical officer to tell us, and thank God is my former student, and one of the subjects I taught them was gender and health. Now, being in at least she was at the ministerial position in the ministry as Deputy Permanent Secretary responsible for health, and also right now she is a chief medical officer. Maybe is it possible for you at least to outline a bit what is it that in the government doing to ensure that the issue of gender is addressed in the leadership?
Thank you, Madam Moderator. Good morning, everyone. You can now at least imagine being her student, what it means. But I must start by appreciating her a lot. Actually, I must say she's one of my mentors. And this is how she is. She was very pro-women, and I'm glad to be one of her products. So let me start by saying that actually the issue that we're discussing right now lies very close to my heart, but also it's very deep or very close to the National Development Agenda. Dr. Semakafa said it very well. If you look at the numbers, we recruit more women, but we have very few women in leadership position. And to me, this is not only an issue of gender, but also it's an issue of really whether we are satisfying the people that we are serving. Because when leadership reflects the diversity of our people, we come up with solutions that are very inclusive, but also that are very equitable and which are more effective. But before I go to what she just asked me to contribute, I just want to highlight a few things. Why do we have less women in the health sector at that leadership role? One, I would say it's individual factors. We can't force someone to be a leader. You must be ready to be a leader as a woman. You must have all the competence that it takes for you to be a leader. And you must have the confidence that it takes to you to be a leader. So I've been across different places in the country, and you look at a young nurse, at a doctor, a lady nurse, and you see all the qualities, but they're not ready for so many reasons. So how do we start forcing them? I think I'll come to that, because we've put some measures to try and, help them to rise through the ranks. So that's one thing. But I think the other one is organizational factors. Some of our organizations actually do not have strategies in place that encourage women to take those leadership roles. I remember there was a time I was the regional medical officer, and I had very young kids, and you can imagine, I want to breastfeed my baby for 6 months, okay, exclusive breastfeeding. And then my office does not really give me an opportunity to do that. I was the regional medical officer here in Dar es Salaam. You can imagine the traffic from where I am. Yes, the policy is very clear that we should do that. But how do you facilitate me to breastfeed my baby? Maybe at the office, do we have a breastfeeding room? So there are some organizational factors that are also hindering women from taking those leadership roles. So if you ask me between the leadership role and my baby comes first. Yeah, and I would forfeit your leadership role, but I go for my baby. But the other one is the societal factors, okay? The way people perceive. Are women perceived as leaders? Okay, so those are some of the issues that we also need to look at. So what has the ministry or the government done in terms of supporting women actually to go for these leadership position? Talking of the ministry cannot exist in isolation, because we have a bigger framework now, which is the government actually, which directs all other governments, all other ministries, what exactly they should be doing. So one, I must tell each one of you that as a Ministry of Health, we are committed, okay? If now you go to the government city in Mtumba, okay, the new government city in Dodoma, when we were asked to give our comments in the infrastructures that are being constructed in Mtumba, one of the comments that we gave is that each ministry must have a breastfeeding room for women, okay? And there has to be a room where women can keep their children, okay, while they are working. So if you go there, actually most of those facilities, they already have those rooms. But in one of the offices I visited, I don't know whether there were no breastfeeding women or what. The room was full of files. I don't know what's going to happen, but at least the room is there. So one is to support affirmative action. So when you talk of affirmative action, actually these refers to special measures or policies that have been put in place to make sure that those groups who for some reasons were left behind, actually they are also supported in terms of taking them from their very low positions or creating an environment that will allow them to also achieve those leadership levels. So talking of those groups, you're talking of women, you're talking of young people, you're also talking of people with disabilities. So that's one thing. But again, if you look at the Constitution of the United Republic of Tanzania, okay, Article number 13, it also subscribes to those affirmative measures, as well as the Employment and Labor Relation number 6 of 2004, Section 7. It also subscribes to that.
Okay.
But
I want maybe first, because you raised a very controversial issue, which I think the Engender Health, which work with the grassroots, might have a response. Why do you say you see the capabilities but people are not ready? You have already created creches. You have constructed creches at the offices at the government city, but you went to one of the facility, there was no child there. Do we have daycare providers, the one employed by the ministry to take care of the children? What are the social relations? Now maybe this one, if we have Dr. Anna Temba, might at least share with us the experiences of the grassroots, which might be response to what you have just raised. Why do we hesitate to take our babies to the creches? Those places for breastfeeding, they're called creches. Karibu, Doctor.
Thank you, Prof. So, looking at the grassroots, at the communities, yeah, and partly, building on what Dr. Grace mentioned. First, we know education is one of the biggest investment to get women into leadership. However, the journeys of girls is very different and not very easy. So one, there's still some families where girls' education is not a priority. So yes, they might go to school, they might finish primary school, and when they're transitioning to secondary, they will just go to tick the box that what they transitioned, and after that, they are no longer going to school. So that is one reality. Second, menstrual health and hygiene is still a nightmare for some of the adolescent girls. So they will be going to schools, but the days when they're on their menses, they will not be going to school. So that also has an implication in their future trajectories. Again, teenage pregnancy and early marriages is still a reality. While we know there are quite a few policies that really ban early marriages, but they are still happening. Some regions more than others. And once you are married off early, there is also a lot in your potential that is being kept into unhealth. But again, even when you advance later on in life, imagine you are today finishing your med school and all that, you got married, and you are told that you have to pursue your education elsewhere. There are so many people who will give up that opportunity because, I'm married, my husband does not want me to do that, or what will I do with my kids and all that. If the sponsorship or that opportunity does not cater for the family, that is also one of the reasons why women will not advance into their education. But again, there is also a very big gendered misperception that men are natural leaders and women are natural caretakers. So leadership is for men. And when that nature, we have that perception, which again affect the workplace culture. So when a man is there and they have to make a decision, they will choose a man because they're a good leader, and they will not choose women because they're weak, they're emotional, and they're just there to take care of the family of other people. But again, it also affects the women. When these opportunities come, they don't actually pursue them because they don't think that position is for the woman, it's for the men who are always taking up leadership. But again, most people aspire to what they can see or what they think is possible. when in the communities we don't have women role models who are leaders from the family levels, from that community, women, and girls, they don't actually see they can actually be big leaders in their communities or even in their workplace. So I think that's another area that we really need to work on, even if it's to keep, like structures that, will make women come up. But before we go, something that Dr. Grace mentioned as well, who is responsible for the domestic chores at home? It's the woman. You feel like it's your responsibility to stay home, take care of your children, even when you have an opportunity to network or, with other people who can actually help you advance, or take an extracurricular activity, that is going to give you like a spotlight with your skills. You actually think, you know what, I need to take care of this, I need to take care of that, I need to take care of my baby. And, so that again is also a big barrier for women, to really advance. But again, who makes decision in the family? Thank you.
I'm really honored today we are discussing this, and all my panelists are medical doctors. And when you are talking about medical doctors, you have 5 years, if they don't have to repeat a year. And then you have 6th year, which is internship. And then you start fumbling with employment and things like that. I really want us to discuss in that parameter. We are talking about systemic barrier. Yeah, whether we like it or not, we have culture here. We have also, even medical doctors are people with ambition and vision, what they want to become. But you can say you met Ave Maria there at Kimbiji. Yeah, she's there, and you see her very well organized, and she has all the leadership quality. But she doesn't, take the offer or the opportunity are there, but she doesn't grab it. Why do we think that is one? So with this one in mind, and taking the government position that, Tanzania is for both men and women, and that it will promote the welfare and opportunity for both men and women. Maybe Dr. Mfaume, you are now, I think, the major employer of the healthcare workers in Tanzania. PRAG is the one owning all the district hospitals, all the national health center, all the government health centers, all the government dispensaries in the country. Now, maybe you can share with us, what is it that you think you as a government representative can do to address these systemic barriers? Karibu.
Thank you very much, moderators, and thank you very much, the researchers, for the very interesting study that was conducted at the primary health care. I want the audience, to focus on the primary health care rather than focusing on the PRAG alone. PRAG has a mandate to supervise the primary health care.
No, I said as biggest, or I think the chief employer. Okay. You understand?
Yes,
because
I understand.
All those workers at the wanaita nini halmashauri, manispa, and whatever, they're all under the PRAG. So for you, that is the position. So, at least if you can share, what is the commitment? What are the strategies that are set there for you too? You understand? We are not taxing you as Dr. Mfaume. No, you cannot do anything. But is there anything in place that at least you think can support this initiative? Karibu.
Thank you again. I will clarify later why I've focused on primary health care more. But talking about the gendered leadership is a reform. It's not an issue that focuses on only one factor. As a PRAG, our core mandate is really ensuring that the guidelines, the regulations, the compliance framework are clearly put into practice, and really we achieve what has been intended in the strategic framework. So one is ensuring that there is a strategic alignment in terms of policies, in terms of strategic plans. And talking about the guidelines for recruitment, guidelines for example, for gender and women developments, It's our role as a pure large to translate it and to put in action. But verticality sometimes, fragmentations of the guidelines is a challenge. So it's our role also to bring together different stakeholders. Stakeholders like the public service commissions, public service management. Public service management provides the guidelines for recruitment, as also guideline for even promotions to a certain leadership positions, including the S sector, middle levels, and senior staff. So having a strategic framework for aligning the gendered leadership selection framework is very key, and that is our mandate. And we have started pushing it forward. The other issue is, as a pure large, is really engaging the stakeholders. The stakeholders are like researchers, the academic institutions. When we're talking about gender, Prof, as you have clarified it area, it's not about women. We should not leave behind boys and girls, but talking about the leadership positions, we have to focus also these employees in services staff. So the other issue also is that we have seen, and as a pure large, we are really intervening it, is selection, gender-sensitive selection processes in terms of promoting the district medical officers, the regional medical officers, the RHMT, the CHMTs, and the medical officer in charges to the leadership position. That is very important, because we have seen it sometimes due to very unclear guidelines sometimes, or fragmentation of some guidelines, that has been a barrier towards a successful gender-sensitive, gender-responsive selection processes. So also the other issue that we as implementers, as a pure lag, is having a robust M&E systems towards the gender leadership framework performance indicators. So that's where we are working with the partners as well, really to define the key performance indicators and to monitor. But let me be honest, for the RHMTs and CHMTs, at first it aligns with the 25% of the research findings. But really, for the RMOs, we are struggling it. And the factors have been mentioned by my predecessors. There's been several factors. We have been taking affirmative action sometimes, but sometimes the work-life pressures, you can attempt to go and directly identify a potential women reader who can be a DMO or RMOs. But really you are disappointed by other factors that have been mentioned, including work, life pressures, and so forth. Thank you very much for that.
Yeah, in fact, that is systemic barrier. You are talking about women being penalized by their biological, duties. This is what we call systemic. You know this one, because I've said in some of the discussion, that one is too young. If you appoint her, she'll start having babies. That is production of the labor workforce. But that is the thing which is being discussed whenever the promotion, whenever the appointment comes in. And in fact, sometimes they create, once you accept that one, they create environment that is really not supportive. And that's why we are talking. We need to see the government instituting guidelines, instituting environment that will support even women not to be affected by their biological responsibilities and things like that. Right now, women are being penalized by their biological responsibilities. In schools, it is the same, although the Minister of Education now is campaigning about, promoting how girls cannot miss schools and whatever, but it still starts from there. So I think the GLASS project still needs to identify. It came in the right time to bring up this discussion so that at least all of us can start seeing the importance of it. So maybe now to share experience, because the first presenters are from Tanzania. Now we have Dr. Com Henry from Ireland. And maybe if you can share with us the Ireland perspective on what health systems or policies have been most effective in promoting women participation in the leadership, especially in the health sector.
Completely aware I'm the only person here who's not a former student of yours.
Okay, now 3 claps for her. 3, only 3. Pasha, 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 Choma. Okay, karibu sana.
I am getting on in years, but I'm available to be a student, depending on. So our country has undergone enormous social change in a short period of time. Discrimination is enshrined in our constitution and our law. In fact, our constitution still states that women should not be obliged by economic necessity to engage in labour to the neglect of their duties at home. That's from 1937. It's still there. And then, as our ambassador said, we had laws and regulations that followed that, because our constitution set vision and direction to people, and the laws followed, so that there was a bar that once women married, they had to give up civil service jobs, teaching jobs. And it was, people often wonder how things change. It starts with some very difficult people who are contrarians, people who object, people who are by themselves and operate in a very isolated space, and that leads to law change. And 1973 was when the marriage bar was lifted. And then there's policy. We brought in policies followed, because once the direction began to change, and that we became equal opportunities employers, which is important, so that we interview people in our health service based on their competencies, not on their gender. Our panels, we work towards having what's called a gender balance in our panel interviews. It's very important. We are obliged by law to report on pay differentials right across the public sector. And we have what are called family-friendly projects. So that all sounds very good, and it's positive. Yet there's a long tail to that constitution in 1937, a long ripple effect, because the catch-up takes many, many decades. And it's often said that culture eats strategy for breakfast, that you can legislate, you can introduce policy, but behaviours and culture mean that the actual impact for women lag behind. Where is the progress? Well, here's some, we have 6 regions in our relatively small country. 4 of those regions are led by women. That's recent interviews, and that's a direct result that they were the best people for those jobs. Our senior consultant posts, our senior hospital specialists, the oldest consultants in the country, over 65 years of age, over 60 years of age, 3/4 are men and 1/4 are women. Younger consultants, it's 50-50, and among our trainees for leadership posts, it's a majority women. So there is progress there, but the big challenge is translating policy into real action. And the problem we have, and the problem I think we share with you, is when you look at senior positions, the job description says you will be available for 39 hours a week. But in reality, it is expected that you are available, like the ambassador, at the end of a phone, at 11 o'clock at night, at 6 o'clock on a Sunday morning, even when you're on holidays. So there's a gap in our behaviours between what we say the senior job description does and how we expect those people to lead. And the stark truth is that gap is not conducive to enticing women into senior leadership positions, those who are balancing the needs of raising families and with their career ambitions to reach senior positions.
Thank you very much, my team here. And in short, what has been shared here is that, number one, we have cultural and traditional barriers, because the way we are raised, the way we are socialized, women are taking the low profile. They are supposed to have that responsibility of unpaid caregiving at home, And that's why she was talking about, you know, if I'm to choose between my child and work, then the child comes first. I have the in-laws who are sick, or my parents are sick at home. It is the woman who is supposed to be responsible for those ones, and literally they make the situation a bit complicated. Number two is what we call perpetual cycling, okay? Because since we don't have anybody at the top who understand the challenges that we are facing, then we continue. Msichana, when a girl is a young girl, a young woman, if you employ them, my dear, their work will be interfered with, their childbearing processes and whatever. So this again become another problem. Another one is that, you know, tunasema, we say that we need both men and women in the leadership. The reason why we need them, number one, wanaume hawakimbii vita. Au sio jamani? Wanaume wanakimbia vita. Men don't run away from war. When it is war, they confront it. But women don't run away from war unless they first take care of their children and the one around them. So the good thing is, before, if you have this one who is confrontational and this one who has the reasoning behind, whenever the situation in the leadership, whenever making a decision, you'll have a best decision ever to move forward. Because for men alone, we are where we are right now. So we really need women to make them, you know, speed up with confrontation so that we progress together. Sijui tuko pamoja hapo. So this is one of the problems. So perpetual cycling is what we are facing right now. You go to the villages or to the rural areas, to the district hospitals, you find medical doctors with capacity, but they cannot move forward. So the situation is not only for Tanzania. We have the sharing from Ireland. They're facing the same problem, but literally what is missing is the government commitment. How is the government commit itself to, because just putting the guideline and the laws and everything does not solve the problem. We need to have supportive mechanism so that those implementation of those guidelines can lead to a positive result. This is what we are talking about. So the GRASS with the mentorship program, maybe I really support you because I remember University of Dar es Salaam when it was faced with a small number of women staff, female staff and students in the science and engineering, they embarked on affirmative action. And mentorship was one of them. Right now we have numbers, including the current speaker, national speaker, Tulia, went through that mentorship program. So literally for GRASS now to be specific for the health sector, I'm sure if it is scaled up, it will assist in breaking that cycle. So please, before I allow the question, let us give our who can lead us in thanking our panelists here before I put the floor there? Katanta. Yeah, I have students, so please. Katanta, tunawapashiaje hawa? Yeah.
If I say hello, you say yes. Hello? Can we stand? Yeah. Yeah, so if I say do I do, you do. Do I do? You say yes I do. Do I do? Yes, 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 hey, do I do? Yes, I do. Do I do? Yes, I do. Thank you.
Okay. I think that was a welcome now. For anybody who has a question or contribution, I think we give, I don't know who can assist to I need maybe, okay. And if you direct your issue to any of the panelists, please mention your name. Now I'll start, kaka, naanza na kaka, nakuja na dada, nakuja na dada, nakuja na dada, nakuja na kaka. And then it will be first round. Then it will be second round. Okay.
Yes, thank you very much for this exposure. Thank you, Aitebo, and the panelists at all. I'm going to use Swanglish as our Prof. Dan, so I hope we are going to be okay, and together too. Coming to infrastructure, tunapozungumzia swala la miundombinu na issue nzima ya glass katika taasisi zetu, kwanza tunafahamu kabisa kwamba lengo la glass is true na linaenda kutengeneza kitu ambacho ni very productive at our national level. But tukija katika swala la miundombinu, nirudi pale kwa Madam CMO. Tunazungumzia swala la BOQ kwa upande wangu. BOQ zinazoenda kuandaa na kujenga. Thank you very much. Shukran. Tunazungumzia swala la BOQ. BOQ ambayo inaenda kutengeneza dispensaries zetu, health centers up to the other facilities at the national level. Mama ambaye ametoka kujifungua ambaye ni civil servant, mtumishi wa umma, anapata ile likizo ile ya maternity leave. Lakini back after maternity leave anavorudi kazini, kwa upande wa medical personnel, anakuwa na ule muda wa kuingia kazini let's say saa 1:30 mpaka kufikia majira around saa 6 saa 8 anawaza kwenda kunyonyesha. So at the national level na glass programmers ambao wamejaribu kutuletea hii project, je, tuna uwezo wa kujaribu kuishawishi maybe serikali ili hii project yetu iweze kuwa improved kwa kuzingatia huu taratibu, kwa maana kwamba huyu mtu all the time atakuwa anawaza kunyonyesha. Thank you very much.
Thank you so much for a great session. So a quick question. I noticed that in the data that was shared by the expertise from Mzumbe, there was a ratio of, you said that there was a ratio of 1:2, male and female mentor. But areas like Makete had a ratio of 1:1. So I wanted to know one of the gap as to why some mentees lacked one mentor, and I need to know what was the predominant gender that was missing. And my second question, one of our mentees mentioned that they have online classes, and I need to know if it works offline for areas that there is internet coverage, poor internet coverage. Thank you.
Asante. Another lady here. And then nitaisha na ile round one. Naomba one question only.
Yes.
We are time bad.
Thank you. My question goes to Honorable Chief Medical Officer. What are the strategies that the Ministry of Health is implementing to actively engage men, especially those in leadership position within the health sector, as allies in promoting gender equity in leadership? Thank you.
Okay, thank you.
Asante na mimi nawashukuru sana. I have just like 2 or 3 points, very briefly. Currently, Care International and the Mwanamke Initiative Foundation of Zanzibar, they have a young women leadership program. I think that program is very good if it could be complemented in the health sector, kwa sababu tumeona mafanikio makubwa sana huko pia. But as Mfaume said, affirmatively, I would suggest, if it's possible, for appointing bodies, if it's possible, to come with a tool which will guide during the appointment to ensure affirmatively there is a balance between women's, men and women's. And lastly, for the mentorship programs, the training, the capacity building, I would suggest as well to have some modules which will involve male participants to see the importance of involving women in decision-making bodies and in management. Thank you.
Okay, number, okay, last one, and then we conclude. Number, we're very brief.
Thank you so much. My name is Generous Oscar from the University of Dar es Salaam. I'm a public health student. I have heard about the GLASS mentorship triad, and it's actually a very good triad. Lakini my question is, apart from the training ambazo unazokuwa unafanya, what other measures or strategies are you implementing to make sure that the trained young leaders or the trained women transition successfully into leadership positions in the Tanzania health sector? Thank you.
Thank you. So I just give 1 minute to Dr. Magembe because at least some issues have been directed to her, and then we close this one for today because we are time back.
Okay. Thank you, Madam Facilitator. So let me start with the BOQs. As I said, instructions have already been given. And even when you look at the BOQs, that is one of the facility that is supposed to be found in a public facility. Of course, there are always issues with finance, budgets, and what, but at least there has to be a facility. And what I mean, I'm not talking about a very fancy area, okay? I'll give you a very good example. If you go to the market in Dodoma, that market there, we instructed them to put facilities for those women selling mboga mboga, the food vendors, the mboga mboga vendors, to have a place where they can breastfeed their kids. So sometimes it's just a room. You don't need a magical BOQ with a lot of budget. So it's our mentality. It's not really the building. It is the mentality. You can have just a small area where women can breastfeed their kids. And for women who are coming from villages and such places, it's not a big deal. Some of them, they just walk home, they breastfeed their kids and come back to work. But going back to the strategies of engaging men, okay? So the issue of gender is not an issue of the health sector. It's a cross-cutting issue. And that's why it has its own specific ministry that deals with gender. And all these that you're asking, they have been addressed, each ministry within its implementation. They have got very specific key performance indicators to deliver when it comes to gender. But just to finish, Madam Facilitator, I would really want to encourage all the women who are here, because we may have a lot of barriers, but let us pick one by one. For those who are sitting here, the mid-career women, those who are already in senior leadership positions, please, I'm not saying that it's very easy to be a leader as a woman. It's not easy, and it will never be easy. If I had time, I would have told you what I've been through to be where I am. So you have to decide that I want to be a leader. Do not accept these things to take you back. One, we have now Uongozi Institute that also have a very good leadership program. Actually, part of it is online. Enroll yourself. I'm very good at sending announcements, adverts on leadership. But colleagues, fellow women, you must have that need from you. You can't wait for someone to make you a leader. Never. Make sure that you have that urge from within. Otherwise, we'll continue holding the second position.
Let me adopt the University of Dar es Salaam strategy. Clap for Madam Chief Medical Officer. Yeah, thank you very much, my panelists. We really needed to have more time for this panel. The discussion is very relevant for all of us because we would have allowed even sharing of experiences of leaders who are here, what they went through for the GLASS project to at least get the learnings which they can improve in their project. But literally, let us be thankful for this short, I can say very short and limited time, but very positive. It has assisted us. I expect that having the government here and having the institutions and all participants here, the need of working together. As Madam Ambassador said, we really gained a lot. Right now, we are busy trying to protect our gains which we had, because somehow they are being cornered and taken away from us. So this is what we are supposed to do. But again, while I thank my panelists here, I want to invite, there is one program which I think I'm supposed to welcome. Karibu. My panelists will go down. Okay. Meanwhile, I ask Dr. Molel to come on stage. Asanteni, naomba tuapishe. Sasa ngoja kwanza apokee. Okay, we want to please hurry up. Tumpishe Dr. Molel. Tumpishe Dr. Molel mara. Hebu acha kushika simu. Sasa tapicha watakuwa haya. Kimbia. Yeah, to just leave Dr. Molel, there is he's supposed, Asante, they are giving him, shikeni mic here. Nani anaongea? Mnaongea ni kutoka wapi? Ninatoka wapi?
Okay, this is from the Tanzania Healthy Summit. The appreciation of your continuous commitment and leadership in strengthening healthcare system across Tanzania and beyond. This goes to Black.
This, she said clearly that this goes to the GLASS project, not Professor Molel alone. We really appreciate and we are so thankful for this recognition. Thank you so much.
Hapa juu hii place na accommodate kukaa watu 6. Wao ni speakers 8. Speakers ni 8. Speakers wako 8. Speakers wako 7. Moderator sio lazima akae juu. Moderator anataka moderator sio lazima akae. Yaani ni hivi, mtu wa juu atakiwa kumwekea mgongo mtu wa chini. Unaona concept? Ndio maana unaona